Hi, everyone. Welcome to Sign Ask a Neurologist podcast series. My name is Dalynah Maldonado-McGrath. I am a third-year medical student at New York Medical College. Today, I have the pleasure of interviewing Dr. Sarah Parauda, who currently holds the position of Director of Mentorship for Neurology Residency at Westchester Medical Center, and who is also an attending neurohospitalist and stroke neurologist at Westchester Medical Center. Dr. Parauda, thank you so much for joining us today.
Thanks, Dalynah, for having me.
So we're going to get right into the questions. Can you tell us a little bit about yourself and your journey to becoming a physician?
Sure, yeah. So I went to, I guess I should start. I grew up right down the street from Westchester Medical Center at Pleasantville. I did all of my training at Cornell, but I guess how I decided to become a physician, my grandmother had epilepsy, and so I was exposed to seizures at a really early age. She's a really smart lady and had actually gotten a temporal lobectomy. And was seizure free for a long time, but then started having seizures when I was growing up. But instead of kind of being afraid of her seizures, she really embraced learning about her condition, and she taught me a lot about it. And I just got fascinated with brain and behavior, and couldn't get enough. So I kind of went to medical school already knowing I was probably going to be interested in all of the brain-related specialties. And yeah, now so I went to Cornell for all my training. I did a stroke fellowship as well at Cornell. And now I'm a neurohospitalist and stroke specialist, which we can probably get into later.
Thank you so much for sharing that. And you talked a little bit about why you chose neurology as a specialty, but were there other factors while you were in medical school that led you to neurology?
Yeah, so I kept an open mind as best as I could. I really liked psychiatry. Was also on the differential, but it didn't have. It wasn't quite as satisfying to me, just because there's this nice localization that happens in neurology, and having the very tangible neuro exam where the patient's in front of you and you find deficits and you can think about where the problem is in their nervous system. And I also thought about neurosurgery, but then I realized pretty early on I don't really care that much about being in the OR or procedures. And I also thought about internal medicine as a possibility, but I wasn't as interested in. I like the rest of the body in internal medicine, but there are some parts of it that I'm not as interested in. Neurology, you really get the benefit of focusing on the aspects of internal medicine that are relevant to the nervous system, and so you kind of get the best of both worlds. So that was my thought process. I also really like that neurology positions you to advocate for people who may not necessarily be able to advocate for themselves as much. I really enjoy that aspect. I find it also always really motivating and rewarding to see people who can still live their best lives, even within the context of their neurological disease that may disable them, either cognitively or physically. I think that's always really motivating. So that keeps me going to work every day.
That's amazing to hear. And so what conditions do you treat as a neurohospitalist in a stroke?
Yeah, that's a really fun part of my job. I get to treat kind of everything, every neurological problem that brings a person to a hospital. So you could think about some of the common things. Stroke, obviously, is a big one. Seizures, and epilepsy in general. When people are having breakthrough seizures, or seizures for other more uncommon reasons, like autoimmune encephalitis, infectious encephalitis or meningitis, brain tumors, all kinds of interesting pathology. People are often at a really vulnerable time in their lives when they come to the hospital. with neurological problems. And a lot of times there's, it's a pretty high stakes situation. You're really trying to preserve their function as best as you can and make a diagnosis as soon as possible. Yeah, so that's, I see, Guillain-Barré syndrome, like I see myasthenia gravis, like anything that can cause someone to come to the hospital for a neurological problem, I see.
That's really interesting. It sounds like it's a lot of variety.
Yes, yes, and I'm sure you remember from rotating on our service.
Yes, I do. And so talking a little bit more about like work-life balance, what is a typical week or day in your life?
Yeah, my days and weeks are very variable because I do both stroke and neurohospitalist work. But a typical week can be, so in general, I work about 30 inpatient weeks a year. Actually, some of that is telestroke, which is not really inpatient. I can be at home in my, well, probably not in my pajamas, but I can be home and see patients from home, which can be a nice break in some ways, although in some other ways it's definitely still have to be on my game in some pretty high stakes situations. So that's some of my time is doing telestroke. When I'm on an inpatient service, I usually start around, I usually will come to morning report at around 7:30 in the morning. And then I will start rounding around 8:30. And depending on what's going on in the hospital, I'll usually leave by 5. Sometimes, if emergencies happen or a lot is going on, I may end up leaving a little bit later than that. And then I work, it'll usually be either 5 days on or 7 days on. I work about 1 weekend a month. And I do sometimes get called at night if the residents see a patient that they think can either leave the hospital or needs to be admitted to my service. I'll get a phone call when I'm on call.
Okay. And so like how different is your current work-life balance to what it was in residency?
I work a lot less weekends, so that's good. I also, it's, different being not at the front line of all of the communications between, different members of the hospital and yourself. I get a little bit of that filter. I have the pleasure of having a lot of residents and advanced practice providers who are really doing a great job being the frontline providers for patients and can filter out some of the questions that they're capable of answering without my help. So that's definitely changed. I am never working in person at night. Like I don't have to go into the hospital at night anymore. So far, I don't anticipate that happening. So that's nice. I can be in my bed and like answer a phone call if I need to. What else has changed since residency? I don't do any clinic anymore. So in residency, you do clinic, and I actually do not see patients outside of the hospital at all, which has its pluses and minuses. It was something that I was hoping for in a career, so I'm really happy about it. But it's certainly not for everyone.
So is that specific to your position as a neurohospitalist that you don't do outpatient work?
Yes, yes. Some neurohospitals do choose to do short follow-up visits with patients they know really well from the hospital. So far, I haven't planned on doing that since we have so many really great outpatient neurologists here who I can connect with and have patients follow up with. But yes, I don't do, as a neurohospitalist, I do not really see any patients in clinic. But as the flip side is I'm expected to be the expert of how the hospital works and how to navigate a patient through the complexities of an inpatient stay.
Thank you for sharing that. It sounds like it can be very challenging, but also very rewarding.
Yes, yes, definitely.
So to continue a little bit talking about work-life balance, you get to go on vacation now as an attending versus when you were in residency.
Well, in residency too, I hope you go to I hope you go to a residency program. They pretty much all now have 4 weeks of vacation a year. So that is no different actually from being an attending. You just have more weekends for you to do short trips if you need to. I haven't gone on vacation yet, but I'm planning on a big trip to Spain and Portugal in the spring, so that'll be good.
That sounds lovely. I hope you
Yeah.
really enjoy your time there.
Yes. And yes, work-life balance is obviously really important, and it's pretty easy to manage that as a neurohospitalist. I guess I mentioned that I have 30 weeks where I'm on inpatient service, and you may have done the math and realized that I don't really have any other specific clinical obligations on my off-service weeks. So that's where I spend a lot of time doing administrative things, like I'm the director of residency mentorship. I'm really involved in the residency in general. I'm reviewing applications for residency, and I'm interviewing medical students for the residency program. So that's a lot of what I do in my off-service time. But it's, a much more relaxed schedule, and I get to, I get to do other stuff that I love, like teaching neurology. So that's cool.
That sounds great. And so on that note, do you have any advice for aspiring neurologists?
Yeah. What could I say? It's easy to get swept up in the craziness of the hospital. This is more just generic advice. It's easy to get really swept up in the rhythm of being a resident, and you may really feel overwhelmed and like you don't have time to see your patients or get to know your patients as much as you'd like. So some advice that another very good neurologist gave to me was to take one patient from your list every day, make a star, and go back and see them again for like 10 minutes at the end of the day. And over time, you change that patient, you alternate which patient you're going to spend a little bit of extra time with every day. And that just kind of keeps you grounded and reminds you what's so great about being a doctor.
That's great advice. Thank you
But
so
that's
much.
not very specific to neurology.
But it's great advice for all
Yeah.
future physicians.
Mhm.
So how do you think the field will change over the next few years or over the next 20 years?
Oh yeah, I mean it's changing constantly. I mean, I've even just like from medical school to being an attending. I graduated medical school only like 5.5 years ago, and even then there were big major stroke trials coming out then that really changed the practice of neurology. We had evidence to start doing thrombectomies in patients up to a day after symptom onset, which was pretty major and really changed how many stroke codes residents get during residency, but also changed it really, broadened the population that we could do, life-changing interventions on. And that's continuing now, even just in the last year, large vessel occlusions with large cores. So big strokes that are mostly completed. We now have good evidence to actually take those clots out too. So things are changing in the stroke world all the time. I guess other things on the horizon. I think prognostication. If people who have had like cardiac arrests and traumatic brain injury, I think we still don't know a lot about what their trajectory could be. Like we tend to be it's tricky to have those discussions with family members because we just don't know. Well, some people wake up years down the line. Some people, are kind of stuck in their bodies without any communication with the outside world. Maybe with normal cognition, maybe with abnormal cognition. And that is a really, really tricky area. And I think I think a lot of people much smarter than me are working on ways of figuring out if there are early clues to help us prognosticate for people in these situations. I don't know, those are the few things, but there's so much, every subspecialty of neurology has big stuff coming on the horizon.
Sounds very exciting.
Mhm.
And we've reached our last question. What is your favorite part of the brain or the central nervous system, and why?
Yes, it's really hard to pick because I love all of the nervous system. I mean, I love all of the brain in particular. Um, I'm tempted to say either the facial nerve, cranial nerve 7 is a really fun nerve, has all kinds of quirks to it. It, I particularly, I spent a lot of time studying it in medical school, actually. I studied smiles in patients with disorders of consciousness in response to comedy videos with Nico Schiff, who is he's a really smart neurologist doing a lot of research in that prognostication stuff I was talking about. But what was really striking was even patients who otherwise were unable to like talk or function would consistently have and even if you ask them to smile on command, wouldn't necessarily smile, but then still had some of the circuitry intact to smile, an emotionally evoked smile in response to a joke. So there's just some really interesting hardware involved in the facial nerve and emotional circuitry in general that I have developed a bit of an attachment to because of some of my experiences in medical school. I'd say also the thalamus is my other one that I respect because the thalamus, lesions of the thalamus can cause pretty much everything weird. So those are my two favorites.
Thank you so much for sharing that. And thank you so much for your time today. Your insight has been so valuable. And it's been a pleasure to interview you. Thank you
Thanks,
for your time
Dalynah.
and contributions.
Thanks, Dalynah. Thanks to the sign group at New York Medical College.